All right, now I've got two questions in the last 5 minutes where it overlaps for both of you. Okay. So, one of the things I worry about a lot with ADCs, with radiation, is an overlapping toxicity, pneumonitis, right? Inflammation of the lung. Talk us through, from both of your perspectives, sort of the risk and management of pneumonitis based on your specific modality of treatment, the systemic option. Either you can start first.
I can go first. So yes, that's a big issue for ADCs. And as I just mentioned, most of the ADCs are approved in advanced lines, right? So most of these patients will have had received immunotherapy in the prior line. Immunotherapy by itself can cause pneumonitis. So for my end, as a medical oncologist using drugs, if I have a patient who had developed pneumonitis on immunotherapy, I would be very cautious in using something like TDXD, let's say afterwards, or maybe like day two afterwards, because both of them can cause pneumonitis. We know how to manage these pneumonitis. I work a lot with our ILD specialists in such cases. There are a lot of tricks that you can use in order to reduce the risk of pneumonitis or manage the pneumonitis if you truly feel that the patient can benefit from that particular drug. But always keep that in mind. There's overlapping toxicity between all the modalities that we use, whether it was radiation or immunotherapy or targeted therapy, and sometimes the combination itself. There are trials for, an ADC plus targeted therapy. This combination can lead to pneumonitis, not in all patients, but in some patients. So we have to keep that in mind. Some patients are more susceptible to pneumonitis due to their comorbidities, such as COPD or having some damaged lungs or, any other things that can lead to maybe like autoimmune diseases. So we have to keep all of these things in mind when we're choosing our ADCs.
Yeah, Dr. Reckon.
Yeah, I really struggle on a case by case basis, especially in the modern like antibody drug conjugate era. I have seen reactions, even though I'm treating per guidelines, in breast cancer, for example, concurrent immunotherapy with radiation. There's a less than 1% chance of pneumonitis with treatment for breast cancer. And then, I've seen examples of folks whose breathing is affected, and I've pressed underneath the ribs, and there's tenderness in the lungs when I press on the ribs, like not in the rib itself, but from the inflammation of the lining of the lung. So it's disproportionate to what I ever see with just radiation alone. But per guidelines for breast cancer, you can give it concurrently because the trial did it that way, right? So there's a lot of coherent and defensible ways to practice and whether or not to do things concurrently or break from systemic therapy. And then, for example, not antibody drug conjugates specifically, but EGFR inhibitors, when those are stopped, there's something called a flare phenomenon where kind of the disease can flare up. And even though it was controlled, you can kind of lose control even when people are off those medicines for a week or two. So I really struggle with this on a case by case basis. And as radiation oncologists, especially in the community setting, have to be aware because a lot of times I'm the one making the call, whether or not to stop. My medical oncologist is very well informed. He is amazing to work with, but it's so hard to keep on top of all the new data. And a lot of times when these drugs are investigated, radiation is not allowed on those trials,
Right.
right? And so we don't have that prospective data to help make these decisions. So that's why, like I mentioned, I'm working on an app to help make these decisions easier based on how the drug works or mechanism of action and the biological half-life. But in reality, we're doing like our best guess, of how long to stay off medicines because a lot of these medicines are known to improve survival. And I kind of worry about flare phenomenon outside of folks who might have targetable mutations for lung cancer. So, yeah, in brief, I struggle with this on a case by case basis. And it's the decision that is made by your local oncology team.
Yeah.
And often they're not really easy decisions to make.
So is there a perfect washout period that you recommend for each of these cases?
So, generally speaking, I like two half-lives, but often that's not feasible. For example, in small cell lung cancer, which isn't the topic of today, tarlatamab, that
Yeah.
has I think it has a 7-day biological half-life. But then, you have to do the building taper up dose. And so
Yeah.
I have to give radiation quickly, and I allow 1 week bookends, which is one half-life. But ideally, when we're worried about toxicity, I like at least two half-lives. But feasibly, we don't have that time to do it. So
Okay.
it impacts my recommendation of number of treatments as well. I'm curious of your biases as well on this.
So if I use the example of, the number circulating between medical oncologists is like 6 weeks. Why exactly? I don't know. I mean, as far as I know, there is no real data. But sometimes we see these like second opinions or consults where the patient had already started chemo and immunotherapy, and then it turned out the patient has a targeted alteration that you can use a drug for, targeted therapy for in the first line. So I stop immunotherapy. I allow maybe like 6 weeks, maybe like 2 cycles of chemotherapy until I start the immunotherapy to prevent or to try to reduce the risk of the overlapping immune toxicity, mainly pneumonitis. So, in our world, it's 6 weeks, but it's a case by case situation.
Yeah, and I'd just like to add to immunotherapy just real quick. I'm
Yeah.
fine with single agent immunotherapy as long as it's not CTLA-4, and it depends on the dose. But dual agent immunotherapy, I get a little bit of cold feet depending on the scenario. But single agent, I'm usually fine to do concurrently. And then one other thing I think of, as long as I can wait, because the average time to response on immunotherapy alone, so that's what we're talking about now, just immunotherapy alone. But the average time to response, generally speaking, is 2 to 3 months. So if I feel comfortable to wait, like if it's not right around the windpipe and I'm worried about, maybe trying to keep the lungs open with radiation, I like to wait 3 months because the average time to response on immunotherapy alone is typically 2 to 3 months. And that's also the average time to toxicity. So if I know that those patients are going to tolerate immunotherapy well, I don't like to do both at the same time to begin with sometimes. So we know like who done it if people, have a side
Okay.
effect. But yeah, I just wanted to touch on that since we were mentioning immunotherapy as well. I hope that wasn't too complicated though. These are such complicated topics. They really are.
Yeah, no, thank you both for really unpacking these gray zones in thoracic oncology, to be honest, right? Not every patient case nicely, neatly fits into the algorithms that we have, right? There's a lot of nuances that go into this. So thank you both. Don't worry, guys, they're going to be rejoining us for the final panel. Keep your questions coming. But I really want to thank you both for kicking off this program very strongly. So thank you.